those of you who've not attended a Bare Bones before, this is the monthly teaching for people who are pre-registrar. Everybody's welcome from medical students upwards. And from 8 p.m. onwards, we do the FRCS focused full BOTA Sunday supper. So this is the fourth session so far. So we've been slowly getting our way, moving our way proximally on the upper limb, and next month will be spines. So I'm doing the shoulders bit of the head, shoulders, knees and toes. This is really trauma focused. The aim is that it should be reasonably clinical, and it assumes only undergraduate level knowledge of anatomy. So the four topics that Tom and I have decided are appropriate to talk about is clavicle fractures, acromioclavicular joint disruption, proximal humerus fractures, and also glenohumeral joint instability. And you can see the diagram there. So I'm moving through this from medial to lateral, from the SCJ, ACJ, then glenohumeral and proximal humerus, as we've discussed. So, but I'm not going to go through this in the traditional way by talking through lots of osteology, because I suspect that most of you know that pretty well. I'm going to try and focus on the synergies of different parts of the body in movement. I think most of us learn, the pectoral region, the anterior compartment of the arm, the posterior scapula, but actually a lot of these muscles are working for us all at the same time. So with this slide, I'd like you, if you could, to think of or write down, whatever works for you, one muscle that does flexion of the glenohumeral joint, one that does extension, one medial rotator, and one lateral rotator. So just a couple of seconds to think about that first time round. Okay, so this slightly busy slide has got 4 images on it, and I'd like you to identify which of these images has each of the muscles that you have identified on it. So which of these images has got your flexor on it, which of them has got your extensor on it, and so on with the rotators. So each image, so there's one image here which shows muscles which flex the shoulder, one image which shows muscles that extend the shoulder, one image which shows the lateral rotators, and one image which shows the internal rotators. And can you guess which is which? And I'm going to put the answers up now. Okay, so the left-hand image does flexion, then extension. Then on the right-hand side of the screen, we've got the external rotators and the internal rotators. Now, you've obviously written down or thought of a muscle in each of those groups. Now have a think about the muscles there that you don't recognize or that you hadn't thought of as muscles that would assist with that particular movement. And now just have a think about what innervates them. I'll put the answers up on screen in a second. Okay, so flexion, a number of muscles there. There are, in fact, even more muscles that could potentially act as flexors of the glenohumeral joint, depending on the exact position that you've got the upper limb in. But obviously, the major ones that you're probably thinking of, including deltoid, long head of the biceps, and pec major. Extensors, again, now the posterior fibers of deltoid, lat dorsi, and in terms of the triceps, which we tend to think of course, it's only the long head because the other two heads extend the elbow. And then on the right side of the screen, you can see the lateral and internal rotators there listed as well. So I'd now like to think about some abductors, abductors, if you will, and adductors, adductors. And noting obviously that when you abduct the glenohumeral joint, beyond a reasonable degree of movement, actually the scapula rotates as well. So you need additional muscles that are going to help you by rotating the scapula. So if you could think again for me about one abductor, one adductor of the glenohumeral joint, and a rotator of the scapula. So 3 images again, exactly the same format as we did for the previous movements of the shoulder. So identify those 3 muscles that you've thought of or written down, and identify which of these images, therefore, shows abduction, which shows adduction, and which shows the rotators of the scapula. I'm going to put the answers up for you now. Hopefully no surprises. And have a think. There's fewer muscles on show now, so we can ramp up the pace a little bit. So which of the muscles didn't you think of? And are there any that you don't recognize? And then finally, thinking about which nerves innervate those particular structures. So, and you can see that, as with the other images, I've put there the spinal roots, which provide the majority of the innervation for those particular nerves. Okay, but it doesn't end there, does it? Because the upper limb is extremely flexible, can move in many different planes, and we have protraction and retraction of the scapula to consider as well when we're really reaching for a distant object. And equally, when we're really reaching high, we need elevators of the scapula, and also then coming back down, muscles which depress the scapula. So now 4 muscles to think about again: protractors, retractors, elevators, and depressors of the scapula. A couple of seconds to think about that. I'm going to put the answers up now. Well, the images, I suppose, rather than the answers. So hopefully the muscles that you've identified are on there. So which of these images shows which of those movements? Which shows protractor muscles, which shows retractors, which shows elevators, and which shows depressors? Answers coming up. And then, which are the muscles that surprise you? Can you identify them, and can you remember their innervation? Okay, answers up on the screen there. And we're going to move on now to the more clinical part of the talk, and hopefully that's allowed you to warm yourself up and remember the anatomy surrounding the shoulder without being too didactic. So I'd like to focus on the right-hand image here, because I'd like to think about the neighboring structures to the clavicle. So in clavicle injury, what are the structures do we need to be aware of? Well, if you have a really high energy injury, then you can actually have dislocation of the clavicle medially. And that's really important, because you have immediately behind it some of the great vessels. So here you have the brachiocephalic vein, which splits into the jugular vein. And you have also immediately behind that the common carotid artery and the subclavian artery. And then both of these move into this green structure, which Gray's shows us really nicely. And that's the space occupied by the axilla. Obviously, the yellow structures moving into that are the component parts of the brachial plexus, which I'm not going to talk about in any detail, but those have an intimate relationship with the subclavian artery and vein, as those then move distally towards the upper limb to become the axillary artery and vein. The image doesn't actually show the apices of the lung, but it's worth saying that the apices of the lung actually poke out cranially just above the first rib, and are therefore prone to injury as well. And that can also be the case intraoperatively if you think about yourself putting screws potentially vertically down through the clavicle. I'd like to move on to the smaller image now on the left-hand side of this slide. And the arrows in this image are showing you the deforming forces which are acting on the fractured clavicle. So why does a fractured clavicle look the way it does when you see it on most x-rays? And the reason is, firstly, you'll normally notice that the medial fragment is moved cranially by the muscle fibers of sternocleidomastoid. And although laterally trapezius is acting in the same plane, the reality is that the weight of the arm is normally pulling the lateral fragment caudally, and pectoralis major is shortening the clavicle as well, which provides that image of the clavicle that you all probably know. And It's worth having a think about what imaging we can order and what the clavicle actually looks like on that imaging. So this is a normal radiograph of the clavicle, but you would normally get an anterior-posterior view of the clavicle, but you can actually ask for a cephalad view. And what's happening here is that the rays are being angled 20 degrees cranially, which gives you less overlap of the scapula and the clavicle, which means it's more easy to identify clavicular injuries. Going to move on now to the acromioclavicular joint, so carrying on that movement laterally along the shoulder girdle. And I'm thinking here about the big image on the left-hand side of the screen, thinking about the conoid ligament and the trapezoid ligament, which together constitute the coricoclavicular ligaments. You'll often see CC ligaments abbreviated on your take list, and then the acromioclavicular ligament as well. Now, the reason I've put the image on the right there is because many of us are not used to seeing any of these joints from the lateral side, and it's worth reminding ourselves how much of the weight of the upper limb is held by the muscles around the shoulder and how very little bony continuity there actually is between the axial skeleton and the bones of the upper limb. I'm going to move now on to the proximal humerus, and this image here is another lovely image from Gray's, and it shows 3 gateways from the anterior side of the scapula through into the posterior arm. And again, I'm not going to talk you through it. I want to really try and draw the knowledge from you that you already have about the important structures which traverse these 3 intervals. So these are the quadrangular space, which is the central one you can see, the triangular interval, and then sort of carrying around the clock face, as it were, the triangular space. So can you think what structures pass through these areas? Give you a couple of seconds just to think about that. And I've made that image small on the left so that we can focus on the image on the right now. And what I've done, so the image here shows you from the anterior side, if that helps you orientate yourself, and shows us the same intervals and tells us what passes through them. So here now the triangular space isn't really clinically terribly relevant for us. I'd like to focus on the quadrangular space and the triangular interval. And the quadrangular space is important because the axillary nerve in particular passes through it. And this is important because this nerve can be injured at this level in a shoulder dislocation, which we'll come on to talk about in a second. And it also takes the posterior circumflex artery. The triangular interval also extremely important because the radial nerve passes through it, but only very, very rarely any injury at this level. Normally any injury to the radial nerve or profunda brachii will happen slightly more distally in a midshaft aphyseal humerus fracture. So just thinking for a second about what radiographs you may be ordering or you may be seeing that are referred to you from A&E. So again, images of normal radiographs here, not of injuries. So you're commonly likely to get an anterior-posterior view of the shoulder. You do sometimes get a true AP. And the deforming forces that act on this. So in this particular image here, you can see that the posterior-superior fragment is being moved in that direction by supraspinatus and infraspinatus. So that's the fragment with the greater tubercle on it. And then the fragment beneath that shows the lesser tubercle being pulled medially by the fibers of subscapularis, and then the shaft itself being pulled medially both by lat dorsi and also pec major. I've then put on the images here because I particularly like images where we're not used to seeing the joint from that angle. So I'm not used to seeing the glenohumeral joint from the top. And it's interesting to remind ourselves here the relationship between the muscles of the rotator cuff and the bony prominences that you feel when you examine the shoulder. And there's very little space, particularly for the supraspinatus tendon. And those of you who might have done any more elective work, which might seem like a long time ago, will be aware, of course, of injuries to supraspinatus that can happen, particularly when you get degeneration. Thinking about the right-hand image here, I'd like you all to identify at 12 o'clock of the image, the supraspinatus tendon just beneath the subacromial bursa, then moving around the clock face At 3 o'clock, we have the fibers and tendon of subscapularis. And then at 7 and 8 o'clock, the tendons of teres minor and also of infraspinatus. You can probably gather from that that even though you have the joint capsule all around the glenohumeral joint, that there's actually an area of weakness inferiorly, in particular anterior-inferiorly, and that is why the joint normally dislocates in that direction. Another image from the superior perspective of the glenohumeral joint, and just to help you orientate yourselves, I'd like you to try and identify structures A to E. So just take a couple of seconds just to work out what those things are. Okay, so A is the scapula, B is the fibrocartilaginous ring of the glenoid labrum, C, the joint capsule, and D, the muscles of the rotator cuff. With E, just there as a reminder that the tendon of the long head of biceps also does provide a little bit of stability to the joint as well. But it's the middle image on this slide which is the most interesting. And it's interesting because it shows the same image after there's been an injury. And obviously that's not a view you ever see or unless you order a very specific X-ray, is not a view that you would normally see on a radiograph. So structure F is again the glenoid labrum, and you can have a Bankart lesion here. So although this image shows a bony Bankart, shows the injury at point G, a normal Bankart would be at point F. H is showing you the joint capsule, but here you can see that it's been stretched beyond its elastic limit, so has slightly plastic properties, whereby here it's been stretched, and that will result in subsequent likelihood of redislocation. Point I is also important because that's a Sachs-Hill lesion, and that is an injury to the posterior aspect of the humeral head. I'm now going to hand over to Tom Key. Oh, actually, hang on. I'm just going to quickly continue with the other radiographs that you might want, particularly in a glenohumeral dislocation. So we spoke earlier about the normal radiographs in the anterior posterior plane. You're most likely in A&E to get a scapular Y view to assist you in assessing for any dislocation, and Tom will look at this in more detail in a second with you. But it is also possible, perhaps more in elective practice, to see an axillary view, and again in trauma to see a modified axial view as well. So thank you very much indeed for listening in. I hope that's been useful to you, and Tom Key is going to take us onwards into the more clinical part of the talk.
Okay, thank you very much, Nick, for a fantastic run through there of the relevant anatomy to the shoulder. Good evening to all of you. Thank you very much for joining BOTA's Bare Bones webinar series. As my colleagues have said, my name is Thomas Key. I'm an aspiring shoulder surgeon currently working as an ST6 in the Welsh Deanery, and I'm going to be talking to you about common shoulder trauma. We'll be working our way around the shoulder girdle in a whistle-stop tour covering clavicle fractures, AC joint injury, proximal humeral fractures, and shoulder dislocation. I hope that this talk will equip you with the knowledge to assess and manage common shoulder injuries and understand the rationale for the relevant treatment options. We'll be starting this evening by talking about fractures of the clavicle. Most commonly, clavicle fractures represent high energy trauma with a fall directly onto the shoulder or a fall onto an outstretched hand where forces are transmitted through the shoulder girdle to the clavicle. It's important for both clinical assessment and when operating on patients with clavicle fractures to respect the local neurovascular structures. Although the clavicle is a relatively subcutaneous bone, there are very important neurovascular structures which lie underneath, namely, as Nick has pointed out, the brachial plexus, the subclavian artery, and the subclavian vein. Clavicle fractures are typically described according to the location of the clavicle in which they occur. They're most commonly classified using the Orman classification, which splits the clavicle into thirds. 80% of fractures occur at the middle third of the clavicle, 15% at the lateral third, and around 5% at the middle or medial third of the clavicle. We'll be focusing on the middle third fractures as they're the most common type of clavicle fracture that you'll encounter clinically in day-to-day practice. It's important to consider the deforming forces which contribute to fracture displacement, as Nick has very eloquently covered, with mainly the sternocleidomastoid causing superior displacement of the proximal fragment and the weight of the shoulder causing inferior displacement of the distal fragment. When treating a patient with a clavicle fracture, you should importantly assess for any other injuries, particularly for high energy trauma, and then focusing on the clavicle directly, assessing skin integrity over the fracture site, assessing the distal neurovascular status, and also obtaining an X-ray series. This should include both an AP and a 15 to 20 degree cephalad view, which enables us to assess the degree of fracture displacement in greater detail. For pain relief, the majority of patients should be immobilized in a polysling. So focusing, as I said, on the most clinically relevant, the middle third clavicle fractures, the majority can be managed conservatively in a sling for around 10 to 14 days before early range of movement exercises are initiated with physiotherapy, but normally avoiding any overhead movements for the first 6 weeks. Serial radiographs in clinic are useful, and that's both to monitor for any early displacement of the clavicle fracture, and then also at a later stage to radiologically ensure that the fracture is united. There are some absolute indications for surgical fixation of clavicle fractures, and normally that relates to open fractures, fractures which threaten skin integrity, fractures with associated vascular injury, and patients with a floating shoulder. And that's a patient who has both a clavicle fracture and also an ipsilateral fracture of the glenoid. There are also some relative indications for surgery, and those normally include displacement with over 2 centimeters of shortening, and also patients with neurological deficit and those that may have symptomatic non-union. Surgical management of clavicle fractures in those deemed appropriate involves open reduction and internal fixation. This is most commonly achieved with a clavicle plate, which can be used in one of 2 ways, either in bridging mode for a comminuted fracture, or with a lag screw and neutralization plate in a simple fracture pattern, which will be amenable to a lag screw technique. Surgery, however, is not without risks, and patients must really be counselled carefully about the risks of scar, wound complications, infections, neurovascular deficit, supraclavicular cutaneous nerve injury, non-union, and also metalwork irritation. And metalwork irritation, wound complications, and the complication requiring metalwork removal is one of the most commonly encountered complications of clavicle fracture fixation. Moving our way distally along the shoulder girdle, next we'll consider injuries to the AC joint, known as an AC joint disruption. Similar to clavicle fractures, these most commonly occur from a direct injury to the shoulder in young patients with a high energy mechanism of injury, such as push bike accidents, motorcycle accidents, and injuries in rugby players. Presentation is usually with pain and associated deformity over the AC joint. An X-ray should be requested, again, including this 15 to 20 degree cephalad or Zanker view to assess the degree of displacement of the AC joint. It's important to consider the structures which stabilize the AC joint in order to understand the grade of injury and also to understand when to consider surgical AC joint reconstruction. Most important to appreciate are the AC joint capsule, associated acromioclavicular ligaments, in addition to the conoid and trapezoid coracoclavicular ligaments, which maintain the congruent position of the AC joint. The Rockwood Classification of AC joint injury describes the associated ligamentous disruption and also dictates a degree of AC joint displacement, and it's graded from 1 to 6, representing an increased degree of ligamentous injury and AC joint displacement. In brief, type 1 represents an acromioclavicular ligament sprain, and the AC joint is still grossly congruent. In type 2, there is both an AC ligament rupture and also a CC ligament sprain with superior displacement of the clavicle. In type 3 injuries, which are the most contentious as to whether they should be treated non-operatively or surgically, this represents both an AC and CC ligament rupture, and the superior clavicle displacement is above the superior border of the acromion. Moving on to the more serious types of AC joint disruption, a type 4 represents both AC and CC ligament rupture, and in this case you have posterior displacement of the clavicle. In type 5, again, there's AC and CC ligament rupture, but in this case, the distance of the displacement of the clavicle is more than double its normal position. In type 6, which is relatively rare, or very rare in the majority of cases, this is when the clavicle is displaced inferiorly below the conjoint tendon. This isn't often seen in clinical practice. Type 1, 2, and the majority of patients with type 3 injuries can be managed conservatively with initial immobilization, followed by a period of mobilization with physiotherapy. Surgical treatment of some type 3 and then 4 through to 6 injuries can be performed using a myriad of different surgical techniques, which are used to reconstruct the AC joint. The most commonly described technique is the Weaver-Dunn procedure, which involves a distal clavicle excision, coracoacromial ligament transfer to the distal aspect of the clavicle, and suture reconstruction of the coracoclavicular ligament. More commonly, newer techniques involved in AC joint reconstruction involve open reduction of the AC joint and stabilization with constructs such as a Lars ligament. Proximal humeral fractures are increasingly common with an aging osteoporotic and comorbid population. And we see two groups in which proximal humeral fractures are most common, either the fragility fractures in the elderly with a fall from a standing height, and less common, but equally important, are the high energy mechanism of injury fractures, which are seen in the young, often associated with polytrauma. Proximal humeral fractures should be considered in relation to the involvement of the humeral head and the associated articular surface, the greater and the lesser tuberosities, and also the humeral shaft. Displacement, as Nick has gone through, is caused by attachments of the rotator cuff muscles relevant to the associated fracture fragments, the weight of the arm, and also the attachment of pec major. Assessment of elderly patients should include a falls workup and assessment for any associated injuries. And particularly in the young, high-energy polytrauma patients, assessment should follow the ATLS principles, identifying and treating any life-threatening injuries as they're found. Focusing on orthopods on the shoulder, it's important to ascertain the function of the axillary nerve, testing the sensation over the regimental badge area, and also obtaining two shoulder views, both an AP and a scapular Y view, to assess for fracture configuration, and most importantly, to rule out any associated dislocation, which really does significantly change management. Proximal humeral fracture dislocations should be treated with caution, and there's good evidence to suggest that reduction under sedation in the ED carries really quite a high risk of failed relocation, with a risk of significant fracture displacement where the shaft is relocated but the head is left in the axilla. Proximal humeral fractures of the surgical neck with associated tuberosity fractures should therefore be reduced in theatre under a general anaesthetic to reduce the risk of relocating the shaft and leaving the head dislocated. Fractures can be classified at the proximal humerus using Neer's classification, and Neer considers both the fracture displacement, angulation, and also the number of fracture fragments. Normally, the absolute indications for surgery were classically thought of as either 1 centimetre of displacement or a 45 degree of angulation, and also increasing parts of the fracture moving up to a 4 part. Often in clinical practice, to aid in decision-making for fractures where surgery is considered, a CT scan would routinely be obtained to clarify the fracture anatomy to plan for the treatment options. The PROFA study, which was really a landmark pragmatic RCT published in 2015, examined both the cost effectiveness and clinical effectiveness of considering either surgery or conservative management for acute proximal humeral fractures. Importantly, it found that there was no difference in clinical outcome for most patients with displaced fractures of the proximal humerus involving the surgical neck, and the paper concluded that surgery is not a cost-effective treatment option. Importantly, however, there were a number of exclusion criteria, and one of those was if there is a clear indication for surgery. PROFA 2 is going to have a look in a bit more detail about the different types of surgery which can be offered for patients. However, the PROFA study has led to an increased trend towards non-operative management in the treatment of proximal humeral fractures, and the majority can be treated with a collar and cuff, followed by early mobilization and physiotherapy from day 10 to 14 onwards. For fractures with displacement thought to benefit from surgical intervention, there's a decision to be made as to whether the fracture is amenable to reconstruction and fixation, or is not amenable to fixation and should be considered for replacement arthroplasty. Typically, the unreconstructable fractures were treated with shoulder hemiarthroplasty, and this provides an articulating spacer in commonly the elderly, comorbid and low demand patients. However, this led to shoulder stiffness as it relies on cuff function for a functional range of movement. More commonly, reverse polarity shoulder replacement is being increasingly utilised, where medialisation of the shoulder central rotation increases the deltoid lever arm, and this gives us an increased likelihood of being able to restore a functional range of movement for the patient. Finally, tonight, we'll discuss shoulder dislocations. Focusing on traumatic structural shoulder dislocations, the majority are anterior and sustained due to a force or a fall onto an abducted, externally rotated arm, and this often occurs in sports. Posterior dislocations are much less common and are often due to seizure activity. The shoulder is an inherently unstable structure, relying on the rotator cuff to centralize and depress the shoulder in the glenoid, supported by the structural glenohumeral ligaments, and with a soft tissue labrum acting to augment the glenoid surface area. Shoulder dislocation in the young commonly leads to recurrent instability with damage to the glenoid labrum, and as Nick has said, that's normally at the anterior inferior margin, known as the Bankart tear. When there's associated anterior inferior bone loss, this is known as a bony Bankart lesion, and there may be an associated Hill-Sachs lesion from impaction of the posterolateral humeral head against the glenoid rim during the dislocation. During patient assessments, we may commonly see that the normal contour of the shoulder is lost, with the shoulder often held in an externally rotated position compared to the contralateral side. It's important for us to assess the integrity of the axillary nerve, again over the regimental badge area, in addition to assessing the neurovascular status of the limb. Both AP and axillary Y views are most important to provide us with clarity as to the direction of the shoulder dislocation. Posterior dislocations may be missed by inexperienced clinicians. The light bulb sign, which is the humeral head with the shoulder in internal rotation, should always raise concern about a shoulder dislocation with further imaging if it's warranted. There are many relocation techniques that have been described in shoulder dislocation, but often the most reliable is the simple traction counter-traction technique when used in conjunction with appropriate patient analgesia or sedation in the A&E department. A post-relocation X-ray is always important, and that's to confirm relocation of the shoulder joint, and there should always be a clearly documented repeat neurovascular assessment to ensure that the patient remains neurovascularly intact or neurovascularly unchanged if there is a pre-existing neurological injury. Initial management of shoulder dislocation involves a polysling support followed by early physiotherapy. And for first-time acute traumatic dislocations in young active patients, investigations would routinely be obtained to investigate for any structural changes, and surgical stabilization should be considered in those patients. Surgery is offered normally with arthroscopy for Bankart repair, and normally that's done in conjunction with suture anchors in order to repair the glenoid labrum and augment this with the capsular repair. In patients with a bony Bankart injury where the soft tissue procedure alone would be unsuitable, as it would lead to over-tightening, a limitation of external rotation, and an ongoing decreased surface area predisposing to further dislocation, this is where bony augmentation procedures should be utilised, such as a Latarjet procedure. So in summary, we've discussed this evening the common traumatic injuries to the shoulder girdle, including the mechanisms of injury, the anatomical considerations, patient assessment and management options. I hope for all of you watching that this will be useful as you embark upon your orthopaedic journey, dealing with these common shoulder injuries that you'll encounter both on call and also in the fracture clinic setting. So thank you very much for your time this evening, and I welcome any questions that any of you have got in relation to both Nick's talk about the anatomy and also my talk about the shoulder traumatic injuries. Thanks very much.
Excellent, guys. Thank you very much. We'll just hold for a minute to see if there's any questions. For those of you that enjoyed that and want to have some more shoulder teaching, we've got in half an hour, we've got some excellent talks with some consultants who'll be doing some FRCS-based teaching. The link is in the chat there. And I'd just like to remind everyone that once this is over, if you could please do your feedback. It really helps us just collating feedback for these events and trying to improve things for you and make things better. So if you could kindly complete that, it's Google Documents. It's like 5 questions, takes less than a minute, and it'll be an excellent help. Don't see any queries, so.
For those of you that may have found this evening's sessions useful, but may have colleagues who are on call or unable to attend, these will be uploaded onto the BOTA YouTube channel so that you can watch them at a later stage.
Yes, thanks, Tom. All of our previous sessions are on both BOTA's website and on our YouTube. So if you haven't already subscribed, we're British Orthopaedic Trainees Association on YouTube. So yeah. Right, well, we'll call it there because there's no questions. Thank you guys for your excellent talks. And if you're joining us at 8, we'll see you then.
Thanks, everybody.